as an alumni of the VCU Art School, I was very excited to see that the medical school and the art school were working together. And with no further ado, I'll let John introduce himself and go.
Good morning, everyone. First, I want to thank Jim for inviting me to share my story and VCU's story of how we've been trying to put art and medicine together for the last 3 years. I should offer you a little bit of background. Number one, I'm not an artist. I draw stick figures. I'm a physician, and I've been on the faculty at VCU for 40 years. I was most recently the chair of the Department of Internal Medicine, and when I knew that I'd be soon stepping down, I tried to figure out, well, what am I going to do now? What's the next challenge that I'd like to undertake? And I heard a wonderful TED Talk by an artist who talked about how she used her art to heal people. And I thought to myself, well, you know, VCU has the #1 public art school in the country, the #2 best art school overall, private and public. And the medical school is located 2 miles down the road. So it only makes sense that maybe we could do something together. So I just went to the art school and began meeting with people in all the various departments, and then met with the dean and told him what I'd like to do. And he said, you know what? Let's make you the inaugural physician scientist in residence at the art school. And I assumed that position, honorary, and began with the artists to create projects, different collaborative projects for medical education and for healing. And so that's the background of how at least I got involved and how many of these projects got started. So at this point, I'm going to share my screen and tell you all the wonderful things that have happened. So, okay. So you'll have to tell me, I'm presuming you can all see this. So the first thing I want to point out is that what we did is not new. Art and medicine have been intertwined since the beginning of time. Here's just a few examples. African power figures that were used to cure mental illness and physical illness. Drawings by Michelangelo, Da Vinci. Poets like William Carlos Williams, who lived in Paterson, New Jersey, and he was a general practitioner. Well, actually, he was a pediatrician. Anton Chekhov, who was a physician, with his novels. And then recently, another example, when I was in Venice, this looks like a church. This is at St. John and Paul Square. This is not a church. This is a hospital. And actually, when I went in the hospital, I saw this sign. On the second floor of the hospital, they had an art exhibit, paintings by Tintoretto, many of which dealt with art and medicine. The problem, though, is although the two have been intertwined for centuries, even more, for millennia, recently, I think they've sort of parted ways with one another. And medicine has become increasingly scientific, and it's lost a little bit of what we call the art of medicine. So, okay. So why do we want to do art and medicine? Well, I think the biggest reason is so that we can gain a better understanding of the human condition, develop empathy, humanity, cultural humility, be able to deal with ambiguity, develop resilience. It also does other things. Art can improve our critical thinking. It can improve specific skills such as observation and communication, and it can heal, both physical healing and emotional healing. So I'm going to focus on primarily art to enhance medical education, art for the practice of medicine, and then just briefly touch on physician training burnout. And you need to understand, I spent my entire career being a researcher. So my goal was to do all these projects within the context of a research study so that we can actually assess whether we had outcomes. It's fine to have sort of a gut feeling that this must be useful or effective, but only through research do we actually know that this is something important that we should implement in our educational system, because whatever you put in, something else has to go out. So art education, art for medical education and for art education as well. So this is the first project I got involved with. I met John Blatter and Jill Ware, and they used virtual reality for what they call embodiment. So look at these two people here. This woman looking through here, when she looks at this woman, she sees herself. She became her, she became her, and she became her. So she's looking at herself. When she moves, she sees herself moving, and vice versa. They exchanged bodies with one another. So we decided to do a project where we would have first-year medical students become an old person. And we did that through several mechanisms. So we went to a retirement home. We interviewed several of them, and then one of them, we took their story specifically. And we created a virtual reality. So this medical student, looking through these glasses, sees this. When he looks at his hands, he sees these old hands. When he looks at his feet, he sees these old feet. And then we used some haptic manipulations. And by haptic, that means sensory. So we put a lead pad on him here, on his ankles, so he would have difficulty walking, feel heaviness when he stands up. We had him do certain things like opening a pill bottle, but we glued it a little bit so he'd have some difficulty opening it, for example. We put a rubber band around him so he'd have difficulty getting out of a chair. And here you can see when he looks down at this pad that we gave him, he felt as if he had just picked up this pad here. So he became the old person, and then he also had to experience some of the frailty of that older individual. We had another group of students who saw the video. They saw this on a television screen, but they didn't go through it themselves. They didn't become that person. We then used validated survey scores and looked specifically at empathy. Was there a difference in the empathy? And there was. Both groups had an improvement in empathy, but the group that underwent the embodiment had a much greater increase in their empathy. So that raises the possibility that we can enhance empathy in our students by having them experience what the person is experiencing, by having them become that. And you can imagine we could do that in several different scenarios for several different illnesses. It's one thing to say, you know, what a heart attack is like. It's another thing if we can somehow have somebody actually experience a heart attack as if they were having it, or experience shortness of breath and what it's like to be somebody who has congestive heart failure. Now we are continuing this study with additional funding now, where we're trying to see, we did this in first-year medical students. Does it make a difference, you know, by the time they become a fourth-year medical student? Or is there a reason we should be repeating this periodically through medical school? We also took medical students and took them to the museum. This is actually not the museum shots. This is where we went through the medical center and looked at art. But we take them to the museum to look at art as well. Again, because frequently the conversations that ensue deal with cultural humility, humanity, empathy, but it can also increase observational skills and help us in terms of errors of critical thinking. So in terms of observation, the average person who goes into an art gallery spends 30 seconds or less looking at any individual piece of art. When we take these students to the art museum, we spend a half an hour looking at a single piece of art, frequently from multiple perspectives, etc. And you see things that you didn't see when you just looked at it in a cursory fashion. And you understand the art better. And you actually can develop a greater understanding of the humanity that the artist wanted to portray. Now, why is this important for medical students? In addition to the empathy, humanity aspect, we've lost the art of physical examination in medical school. In the old days, the doctor would go in and take a very close look at the patient, examine the patient in detail. Now it's all technology. Send them for this, send them for that. So they miss that little dark spot on the arm that's actually a melanoma, or the difficulty breathing because the patient is using accessory muscles. So this is an attempt to have them improve their powers of observation. And in fact, a study was done up in Harvard about a decade ago that showed exactly that. So the bottom line is a control group, and what basically they did and what we've done is you put up several photographs of artwork, and you say, I want you to list everything that you see here in 2 minutes, and the number of observations that's made. So you can see here at baseline, both groups, the control group and the test group, same number of observations. But this group then had their museum experiences, and you can see that their number of observations have increased. So observational skills were improved. There's another thing, I mentioned critical thinking. And this is an example of what I mean by that. Beautiful portrait. I'd like you all to spend just 30 seconds looking at this and thinking about, what do you see? Actually, I'm not going to give you 30 seconds. I'm sure you've already made up your mind. And the answer I get most of the time is you have a mother and her daughter on her lap, daughter holding a flower. That's what I thought. But you know what the truth is? That daughter's a boy. And this illustrates confirmatory bias. We have certain preconceived notions that we bring into the world and then we apply them. Now, in an age of Black Lives Matter, you can see where this might be highly relevant. When we approach individuals and have certain notions about that person that may not be true. It's interesting, an experiment was done where they took police detectives and medical students, and they saw this painting and went through this same exercise. And when they were asked, what did they see? The medical students said, you see a mother with her daughter on her lap. And it was the detectives who questioned that and said, why did you say that? Because the detectives had been specifically trained about confirmatory bias and knew that you just can't jump to conclusions. Another thing that we've done is, this was a study we did using improvisation training. So when you think of improvisation, you think of probably comedy, but that's not what improvisation training is about. It's about training people to listen, to communicate. Now, I want you to think back to your last visit with a doctor. Studies have shown that the average amount of time that elapses between the patient starting to talk to the doctor and the patient being interrupted by the doctor is less than 2 minutes. with a range of 6 seconds to 3 minutes, something like that. I hate to say this since I am a physician, but doctors are terrible listeners and often terrible at communicating. So knowing this, we did a project. We took our second-year medical students. When our second-year medical students are about to go from their basic science classroom studies into the clinical arena, we put them through something we call a standardized patient exercise. So we have theater actors from our theater department who are specifically trained to portray patients. And they've also been trained to be able to assess the communication skills of the medical students. So the medical students go and they have an experience in an office with the actor, the standardized patient, and then they get rated. Well, we took the second-year class, which is about 180 students. 90 of them went for 45 minutes of improvisation training. And the other 90 students just went into a room and, talked amongst themselves. We then had them undergo the standardized patient experiences. And then we looked at the rating. Now, the actors didn't know who got trained and who didn't get trained. They had no idea. They were blind to that. And what do you think happened? The students that had the improvisation training, even though it was only 45 minutes, were rated as much better communicators and much better listeners. There was no difference in any of the other scores, validating the fact that it was a very specific outcome related to the intervention. What difference does this make? Well, if you listen, then you develop a better understanding of what the problem is. And if you're better at communicating, there's a much better chance that your patient will do well. So again, this is something that we are now assessing going forward to see if it makes a difference in the long term with the success of our students. I'll just touch on this briefly and just mention you can use virtual reality, augmented reality for helping with anatomic procedures, training people. Imagine right now the medical students go and when they do anatomy, they have a cadaver. I suspect most of you have never seen a cadaver. That cadaver does not look anything like a real human being. The bodies have been basically pickled for preservation. The skin turns gray, the arteries and veins don't have the normal colors that a body would have. Imagine now that you could put on virtual reality glasses and what you see in front of you is actually a real human body. And using augmented reality, etc., if you were to cut it, you would actually see blood flowing. You could teach anatomy in a much more realistic way. You could do procedures. When you want to teach somebody in surgery to do an operation, you could use those virtual glasses, reality glasses, so that they are experiencing the actual act of doing it. And we recently used the augmented reality for an operation in a young child. I was thinking of showing you the video of what I'm about to present, but I was worried the technology wouldn't work. But a child came in who had a tumor in the heart. And so the pediatric cardiac surgeon was going to have to go in there and do an operation, a very tricky one. So what we did is we were able to do multiple MRIs, so imaging studies of that patient's heart, and then create an augmented reality of those MRI images. What I mean by that is the pediatric surgeon was able to put on goggles And then in front of him, he would see that child's heart. He could turn it around. He could open it up. He could look exactly where is what. He could actually do the operation theoretically in front of him in this space before he actually has to go into the operating room and do the operation. This is what I'm most proud of. We started a new elective in the medical school for first-year medical students entitled Medicine, Art, and the Humanities. And it was a joint collaborative elective between medicine and the art school, and incorporated the departments of art education, theater, communication arts. The goal was specifically to enhance empathy and humanity, and again, improve skills, improve critical thinking. It was an 8-week course, and you can see here it involved going to the art museum, improvisation training, cultural humility, narrative medicine, another art museum, pop culture, creative reflection, capstone presentations. After each one of these sessions, and each session was half an afternoon, the students also had to write down what they experienced and what they got out of that session. So they had to reflect on the experience. I'd like to highlight just 3 of the actual sessions. So cultural humility. So what did we do there? Well, we took the students to Black Monument Avenue in Richmond, Virginia. This is an area that these students would probably never go into. Most of white Richmond has never been to this area. And we actually did it in an intriguing way. We said, you're not driving there. You're going to leave the medical center and you're going to take a bus, just like people who live in that area do, so that you have that experience. And then we went to this center here, where we discussed various aspects of what it's like to be Black in Richmond, dealing a fair amount with the medical school's own history. Recently at VCU, and actually it used to be called Medical College of Virginia, so I'm going to say MCV, they did some construction, and you may have heard about this. They found a well where they were going to put up a building. There was a well, and when they looked in the well, there were human bones. Well, those human bones were the remnants of how anatomy used to be taught at MCV in the late 1800s, early 1900s. Where did the bodies come from, the cadavers? Well, the cadavers came from Black cemeteries. The fellow who was responsible for obtaining bodies for the medical students, he himself was Black, went to Black cemeteries and stole the bodies and brought them back to the medical school. And those were the bodies that the white medical students practiced on. And then the bodies were discarded down the well. Not a very, I'm just trying to think of the word, piece of history that anyone is proud of. That's one of the reasons, by the way, in Richmond, the Black families used to tell their children, don't go near MCV, because they actually thought maybe some of them would get stolen and killed so that the bodies could be used for cadavers. It's one of the reasons why when we do clinical trials, we have difficulty enrolling people from the Black community because they don't trust the medical center. And you can imagine that that was a very impactful discussion for these medical students who'd never heard this story, because at this specific time, they were doing their cadaver dissections in anatomy. Narrative medicine. This is the one I like the best out of this entire course. So narrative medicine has been championed by Dr. Sharon at Columbia University. And she wrote, along with scientific ability, physicians need the ability to listen to the narratives of the patient grasp and honor their meanings, and be moved to act on the patient's behalf. And narrative medicine includes reflection, writing, close reading, observation. As Paul Kalanithi said in his When Breath Becomes Air, and if you've never read that book, you need to. Those burdens are what make medicine holy and wholly impossible. In taking up another's cross, one must sometimes get crushed by the weight. So what did we do? We paired medical students and art students together. So this is a medical student here. This is the art student. We tasked the medical student with going to this patient and writing up a history, but not a medical history, a life history. Find out what that person is about. Ask that person, what do you do? Married? What's important to you? Do you have children? Find out everything you can about that person and their life. And then end it with the question, what would you like your healthcare team to know about you? And inevitably, almost everyone had the same response. I want them to know I'm a person, that I'm not pneumonia, that I'm not an MI. I am a person. While this conversation is going on, the art student is drawing the interaction. When they're finished, they leave, and immediately the medical student writes up the narrative. The art student finishes their drawing. We then make a copy of the narrative and copies of the drawing. We come back to the patient, we give them a copy of each. But then we take the narrative and we plaster it, we tape it to the outside of the patient's door, so that every healthcare provider, nurse, doctor, physical therapist, whoever, when they enter this patient's room, they will have read that narrative. Here's another example. All right, this is the artist. This here is the medical student taking the history. So both the art student and the medical student now develop an appreciation for the humanity of this interaction. The patient is no longer just the patient or a patient. It's Mr. Jones. It's Mrs. O'Hara. The impact of this on the medical students was incredible. The impact on the patients, they loved this. Somebody was actually listening to them about who they are. But what really brought home to me the power of this is an email I received about a month after this course was over from a physician who was taking care of one of these patients. And she wrote to me, she says, John, I have to tell you something. We had a patient in North Hospital, and to be honest, he was a cantankerous guy, and we were not getting along very well. There was a lot of friction between the medical team and the patient. And then one day, we're going to his room, and we found a piece of paper on his door and it telling us all about him and his life. And we looked at one another on the team and we said, we didn't know any of this. And they went in the room and they began talking to the patient. And guess what you think happened, miracle of miracles? She said, all of a sudden he wasn't cantankerous anymore. And our interactions improved dramatically. Again, bringing the art, bringing the humanity back into the medical arena. These are some of the drawings of the patients that were done. And then finally, we had the medical students create art. But the art had to address one of the components or one of the objectives of the course. It had to address empathy or resiliency or cultural humility, for example. And they were incredible. It could be any type of art. So it could be a magazine, a newspaper. Here's a triptych. This is a woman from Egypt, and this is reflecting her background. And they had to explain the relevance of each piece of art. I love this one. When I said we let them do any piece of art, that's a cake. And this is Grey's Anatomy. And this was, so it was a woman who did it. And you look what she wrote here: weak, ignorant, lazy, liar, etc. Very disheartening. Unfortunately, I can't show you what's on the other side. I didn't take a photograph of that, but I should have. It was a woman emerging triumphantly out of the book. In other words, this is what she was experiencing, but this is, on the other side, is what she was able to become. She was able to overcome these cultural biases. So this was an elective we created in the medical school. After it was finished, the art professor came to me and said, John, can we do something, an elective in the art school? He says, because I have these young art students and they are talented and they are ambitious, but they know zippo about life. So the goal here was to introduce the art students to the human condition and to increase their empathy and improve their humanity. And we did that by taking them to the maternity ward, inpatient wards, spinal cord unit, children's hospital, or retirement home. Had an interview with a patient who had cancer in a very late stage, to a community health center, a palliative care unit, and to a cemetery. Sort of like from birth to death. And they based their artwork for the entire semester on this. And again, the students loved the course, and you could tell that they had gained a much greater appreciation for the human condition, a much greater empathy and humanity. So that's what we've done in terms of medical education so far. Briefly, I'm going to touch on the practice of medicine. And the United States is behind the times, unfortunately. In the UK, very soon, you're going to be able to prescribe art, music, dance for your patients. And the health service will subsidize it. We haven't gotten there yet. So here's one illustration using virtual reality. This is an avatar here. And when this person moves his arm, the avatar moves its arm. When he talks, he hears the avatar talking. So our avatar has become him. And we did a preliminary study where we took elderly individuals, and they're in a room alone, and they're talking to themselves. And we had some of those elderly individuals at the end of this session break down crying. And why? They said, I was telling stories to myself that I've never told anyone. They had a catharsis. So when I heard this, with Semi-Ru, who's the one pioneering this, I said, you know what? We should try this in our palliative care facility, where we take care of patients with terminal diseases or chronic diseases, so that they can talk to themselves and experience catharsis. And we did this, again, in a research setting. And we found that the quality of life of the patients improved dramatically. They're not judged. They're in a room by themselves. So they can say anything they want. They can tell any story. They can have any type of avatar they want. They can have themselves be young, old, anything that helps them connect to themselves. We're now looking to use it, whether we can use it in the treatment center for children, where you can imagine that it might help them go through traumatic episodes in their life. We'll also want to go to the Veterans Administration Medical Center and use it in patients who have permanent disabilities in our spinal cord unit, or maybe with patients with PTSD. This is the embodiment that we were talking about before, but now for patients, not for medical students. We just finished one in amyotrophic lateral sclerosis. You know this as Lou Gehrig's disease. It's a terrible neurologic disease where basically you lose all muscle function and lose it slowly. It's a terminal, there's no cure. How did we use it? Well, we made a video experience, not for the patient, but for their loved one taking care of them. So the loved one putting on these glasses and through the other haptic interventions became the patient, the person that they were caring for, their loved one. That enabled them to better understand and experience firsthand what their loved one was going through. It improved their empathy of the situation. It's one thing to see someone in a wheelchair who's having difficulty breathing and eating. It's another thing to be in the wheelchair yourself and experience those things. We're also now going to embark on Parkinson's disease, where the patients will experience as if they were actually moving. They could experience that vicariously, hopefully improving their quality of life. They will also be encouraged to do movement. And we know that dance therapy improves Parkinson's disease symptoms. And this way they would be doing their exercise. Right now, if you want to do dance therapy, you have to get in a car, go to a dance studio, and you might do it 2 or 3 times a week. You could do it now with this virtual reality every single day, several times a day. The Lullaby Project was a project to bring mothers and their children together. This was started at the Carnegie in New York City, and then we did a study here as well, where we took mothers who are going to have their babies, and while they're pregnant, they meet with a musician and they write a lullaby together. And then every day, the mother sings the lullaby to her unborn child. And then when the child's born, continue to sing it. The goal was to create increased bonding between the mother and the child. I will tell you, study was a failure. There was no effect. But I think the problem was we chose the wrong study group. We studied normal women. Well, you know, most normal women don't have a big problem bonding with their child. So now we're thinking of doing a different study, where we're going to use women who have addiction problems, because those women frequently are dissociated from their pregnancy and their child. And could we use this intervention to address their addiction, to enhance their bonding with their child. I love this one. This is a piece of art. I know you think it's a bicycle with a coffee stand, but it's a piece of art, performance art. Actually, it was recently exhibited at the Tate Modern in London. And this is John Fry. He's the artist. John Fry is also a recovered addict. And so how does he use this performance art? Well, he wheels it, and he's strong because it's a heavy cart, all around the college and the university and other colleges. And when you approach him, you get a free cup of coffee. But you know what? He doesn't just pour you a cup of coffee, give it to you. You've got to make your coffee. He will supply the hot water and the grounds and the condiments, but you're going to have to make it, which means you're going to have to stand there for several minutes. And while you're standing there, you are going to have a discussion with him about addiction. What a beautiful way to use art to heal. And then finally, and when I said we use the art school, we use all of it, Department of Fashion, studio design, to improve the experience. Here's a children's hospital that's being built or going to be built. And we're going to use the artist to design ways, interactive ways to improve the delivery of medical care to children. I'll give you just one example. Imagine a child having to have chemotherapy for cancer, a 7-year-old. Right now, they go in the room, they put in an IV, and they infuse the drugs. Now imagine you had a special room where you could say to the child, okay, tell me your favorite cartoon character. And they say, Bugs Bunny. And then you press a button on the computer and all the walls and the ceiling become Bugs Bunny cartoons playing, running around, Elmer Fudd, etc., to distract the patient while they're being administered the chemotherapy, to give them some element of joy during this horrible experience or trying experience. So those are some of the things that we are looking at, not just one, to do in this children's hospital. We also now, as I mentioned, I'm the physician scientist in residence at the art school, and I arranged for us to have an artist in residence at the medical school. Sterling Huntley, he meets with all the departments. He is involved in the children's hospital and in several other initiatives to see how art can be used in the medical setting. And then finally, to close, physician and trainee burnout. You may or may not know that physicians are one of the demographics that have the highest rate of suicide. Extremely high, not in their 20s, but in their 40s, 50s. Trainees, burnout, especially at times like COVID-19, is just incredible. So we're looking at ways we can improve that. One way is we now have a VCU health system orchestra. This is at its beginning, and this fellow here actually is the chief of endocrinology. I happen to be an endocrinologist. This is the Symphony now. And so they play several times a year. They obviously practice all the time. They play at the medical center. We have student groups, the heart program and the human program, where they now incorporate several of the things that we talked about over the course of a year, not as a specific elective. So I'm just going to show you art and medicine in a different way here. This is the Welcome Image Awards that were presented 2 years ago. I just find them incredible pieces of art. But more importantly, I would just like to note that I hope you can appreciate that a wide variety of types of art can be used for medical education, to improve empathy, to improve humanity, to improve our understanding of the human condition, and by doing so also improve the delivery of healthcare and the health of our patients. So with that, I'm going to stop the sharing and open it up to any questions anyone might have.
I'm going to jump in right off, John, and tell you my doctor used to practice this all along, and his great line was, if I let you talk long enough, you'll tell me what's wrong with you.
That's true. That is actually very true.
And unfortunately for him, he retired February last year and suddenly found himself with nothing to do during the pandemic, which is strange. But anyway, please open it up to questions. The other thing I can start with is that as an architect, you know, part of the designing of this class was this, to me, this conflict between technology and you know, the human activity of building, and how now architecture is so dependent on technology, but all of the structure of all of the personal part, the human part of building is taken out. So I was immediately fascinated by the fact that you're using art for empathy, but with the technology.